Welcome to this episode of Orthodontics in Interview. It's my absolute pleasure to have Dr. Sergio Sambotaro joining me from Sicily. Thank you so much, Sergio, for joining me.
Thank you. Thank you to you.
So, I want to give a bit of background about Sergio. Really, today's conversation is based upon the bioprogressive principles and theory, and we're going to dissect how it works, what the evidence looks at. From Sergio's side, he's based over in Sicily, in Italy. He's been an adjunctive professor over the University of Milan and currently is. He's a director of Centro di Ortodontia at COS. He's also the current president of the Bioprogressive Italian Orthodontic Society. We're having their meeting very soon on the 8th and 9th of May in Catania, over in Sicily. He's a member of the European Orthodontic Society and has contributed widely to both the lecture on bioprogressive theory as well as the evidence. So thank you so much for joining me here, Sergio. And really today is looking at the etiology, the mechanics, Anchorage that's been described classically. This all started off with Ricketts, and really exploring where it stands in terms of today's clinical practice and also in terms of the evidence. So I've been doing quite a lot of reading, Sergio, to prepare for this interview. And I'm just going to go over some of the principles I've read about the bioprogressive theory. Correct me if I'm wrong. So I'm going to start off by describing the muscular and cortical bone anchorage, the key component which then dictates how anchorage is managed, but stabilizing the vertical and then the anterior posterior. And I will ask you questions about how that looks. Orthopedic correction in terms of location of the maxilla and the mandible, overbite before the overjet, so essentially the vertical before the sagittal, and the concept of overtreatment in terms of the muscular forces. The last point, and probably the first question, is this concept of unlocking the malocclusion in a progressive sequence. So my first question to you, Sergio, is what is the understanding of the malocclusion according to the bioprogressive theory? How do we unlock this? Well, what is the etiology?
Okay, we think that the malocclusion is a symptom. So when we talk about class 2 or class 3, we define malocclusion essentially like a symptom. And instead, we must look for the etiology of the malocclusion. And from an etiological point of view, we must take account about the function of the oral cavity. And that is obviously the mastication, obviously the swallowing, but we must take account about breathing. If we think that 300, 400 of years ago there is no malocclusion or a little percentage, we can understand that the environment where now we live plays a role in the etiology of the malocclusion, but it is not equal for all the people. So there is a pattern that we must recognize from the beginning of the treatment, from the when we make a diagnosis, because a brachyfacial pattern it's totally different from a dolichofacial pattern in terms of reaction to the environment where these people lives. And so this go through your words about the muscles. So the muscles react in a different way from the forces that came from the environment. And so we must to understand the forces that causes the malocclusion. This is the first point that we take account when we make a diagnosis in this process.
That's great, Sergio. So, in terms of then describing the class 2 and the class 3 malocclusion, in terms of the vertical, how do we understand that? I went on Sado Sato's course, and he described the occlusal plane as being key to that. Can you explain the etiology then of the class 2 and class 3 relative to the vertical?
Yes, sure. And when you say class two, to me, you say nothing. When you say class three, okay, there's nothing, just nothing. Because if we have a brachyfacial patient with the class two, with the flat mandibular plane, okay, we don't want that this mandible growth forward because it's already forward, and it's possible that he is a class two in the class two malocclusion with the lower denture backwards, and it's very difficult to put the lower denture forward in a brachyfacial patient. Instead, when we have a class 2 dolichofacial patient with a steep occlusal plane, okay, this is with the posterior rotation of the mandible, this is a different case. And so in this case, we want to correct the class 2 malocclusion in a total different way. And Ricketts back in the 60s, he explained that we don't have just the teeth, no? We have almost 10 components of class 2 malocclusion. So we have in a class 2, the anterior cranial base is longer, so the maxilla is forward. The posterior cranial base is longer, so the mandible is forward, and the chin. The chin is backward in the class 2 malocclusion. Okay? And also the maxilla, that is the main component, is forward in class 2 malocclusion. And obviously, the front teeth, upper front teeth are forward, and the back front teeth, the back posterior teeth are forward and are not in the vertical, not extruded. So the consequence of this is that the class 2 patient, the oligofacial patient, has a steep occlusal plane because the upper molars are under erupted. And this is the cause because the lower molar is over erupted. And also the incisors are over erupted and forward. And so, in a frame like this, the therapy is very easy to understand. And in fact, the approach that we have in dolichofacial patient, open bite, is to extrude the upper molars with the cervical Headgear. That is the opposite that the people teach at the university. So during the class 2 correction, so we in dolichofacial patient, open bite with high convexity, we want to extrude little bit the upper molar, and this will intrude the lower molar, and so the consequence of this is to flat the occlusal plane posteriorly, and this is what Ricketts called the decompression theory, because the condyle was decompressed, because if you extrude the upper molar, the condyle goes downward, and so you have more vertical growth of the ramus in this patient. And this is Ricketts back in the 60s that he showed very clearly. He published in the Anglo Orthodontist. This is a boundary. And recently we published with the same result at the University of Milan with the Professor Capriolio. We saw this. We saw many times. And so I remember that the Ricketts used to say, I used to say, I'm not sure if I was the first that start to use the eye pool, but I'm sure that I'm the first to do not use anymore, because he understood that in class 2 malocclusion, when you intrude the upper molar, the mandible goes backward. Okay, because during the grow, the condyle, okay, this is Ricketts and also Bjork. Ricketts called this the Ricketts-Bjork theory. And Bjork explained this very clearly. The mandible, when the condyle grows upward and forward, the chin grows backward and forward. When the condyle goes backward, the chin goes backward. And this is what in dolichofacial patient. So the mandible open uh, in dolichofacial patients. So in order to interrupt this pattern of growth, you must to give support to the condyle. And the only way that I know is to extrude the upper molar little by little. If you apply too much force, the dolichofacial patient cannot support this force, so the result is to open the bite, and you have a posterior rotation of the mandible. But if you apply the cervical Headgear in the Ricketts way with the bioprogressive principle, you will see that the mandible will go forward and you will close the bite.
That's a very clear explanation, Sergio. I'm
Thank you.
gonna, I'm gonna. So this mirrors essentially Melvin Moss's the idea of functional matrix theory and how the environment does have a determination to it. But even Melvin Moss updated his theory in 2006, where he included a genetic component. So although you're describing the class 2 as a symptom, ultimately, do you agree that there is a genetic component and therefore things like surgery become incumbent? Or do you think actually at the right time for intervention, we can idealize patients' facial growth?
Yes, so the bioprogressive way is to recognize obviously the genetic components like the 80%, and the 20% is the environment. But when the environment overwhelm the genetical pattern, there you can modify the growth. For instance, not all the brachyfacial patient with the mouth breather, they have very strong muscles. They have a little bit of um, influence on the malocclusion. But a dolichofacial patient that is mouth breather with the very weak muscles, he have a great influence from the environment. So the development of the malocclusion in this kind of subject is very strong.
And in terms of the area you mentioned there, is it possible to, in the growth phase, do you think it's possible to modify the breathing pattern for these patients? Is it a functional change, i.e., thinking of exercises, or actually, if you mechanically create an environment with posterior extrusion, upper posterior extrusion, lower posterior intrusion, are you able to enhance it? What is your modality for correction of this? Is it beyond just the braces?
If there is an obstruction, and the patient has sleep apnea, I recommend to go to the otorhinolaryngologist to in order to solve the obstruction, maybe with the surgery. And then from a theoretical point of view, if you remove the cause, you can recover the pattern, and the growth can go in the straight way. But with the appliance, you give back the form of the maxilla in a very quick way, and so it's easier for the patient to start to have a normal function. This is our approach. So to work together with the other specialists.
Perfect. I understand that clearly. So it's not the orthodontics that are necessarily the solution. There is something which is underlying, but actually you can idealize the environment from that point onwards.
Sure. Yeah.
Um, in terms of looking at the class two, which is the classical description of the bioprogressive theory, you've mentioned cervical headgear, also using utility Ricketts utility arch or utility arches in general is commonplace. And I just want to go through some of the mechanics I was reading about from the JCO series by Bench, which is an excellent series, by the way, in describing this theory, if anybody is interested to read further. And that is the idea of having tip back bends in the lower arch. So you're intruding the lower posterior teeth, you're extruding the upper posterior teeth, as you mentioned, changing the occlusal plane into this counterclockwise rotation. What I thought was interesting is the description of the lack of an intrusion of the lower anterior teeth. What I thought was interesting was the lack of proprioception that was described on the anterior teeth,
Yeah.
meaning the mandible would search, is the words that were used, to counterclockwise rotate to gain the occlusion. Now, I just wanted you to explain that further.
Yes. Thank you for this question. I want to clarify this aspect that is controversial in the field. When you have open bite, okay, you can go backward, okay, without any interferences. Okay, so this is and you can correct the class two orthopedically with no problem, because you start from open bite and you will see that the bite is closed. But when you have a deep bite, okay, high convexity in the dolichofacial patient, you must first correct the deep bite. You must first intrude the lower incisors, and this because to avoid the anterior interferences. Because if you, and this is, you can do it, if you bite in your lower incisors, you have no force. Okay, so when you protect your system. So if you have any interferences, anterior interferences, the mandible starts to go backward. And when the mandible go backward, start to posterior rotated. So you have an effect that you don't want. Okay, so first and when you correct the class 2, if you don't open the bite, you will not see the indifferences, because the mandible goes backward. It's the patient that say to you, oh doctors, maybe I have some noise here in my joint, because the mandible is start to go backward. And so this is because one of the principles in class 2 correction is first open the bite and then correct the overjet. So the only case when that we associated the cervical headgear to another appliances, and in this case is the lower utility arch, is in class 2 deep bite. In all the other case, we call the cervical headgear approach in class 2 bends treatment, because we use just two bends and the headgear, and that's all.
So, if I understand, the idea is to remove the dental interference for the deep bite
Yes,
cases, to then allow the mandible to auto rotate to then resolve the overjet.
sure, you
Fantastic.
understand.
In terms of the prescriptions, now prescriptions are a whole concept in themselves. What is a prescription that you're using to fulfill the bioprogressive principles, or actually is the prescription not as important as it say is for the Bennett McLaughlin the MBT prescription?
I can say that it's not very important prescription, but obviously I use the Ricketts prescription, and I use the latest Ricketts. If you because Ricketts change the prescription from the 60s to the 90s. He changed his prescription, and many people they just don't know that the first straight wire prescription was by Ricketts, because Ricketts, yes, was the first that put a torque in the anterior teeth back on the posterior teeth on the lower, angulation torque on the canine. Then he put inside the in out, okay, and the full torque. He called the full torque prescription. So now we use a straight wire prescription by Ricketts with the 22 of the degrees of torque in the upper central, 14 of torque in the lateral with the 11 degrees of angulation and 7 degrees of angulation and torque for canines, and the in-out for canines and premolars, because we want the canine. This is one of the great differences with the straight wire. In the upper and the lower arch, we want the canine tucked in, not out. We want the canine tucked in and the front the incisors out, because the canine in this way can prevent the lingual movement during the retention of the lower incisors. So, and this is common. This is what Ricketts called the therapeutical ideal, because the Ricketts prescription doesn't came because Ricketts liked the prescription, and because he studied in untreated patient. And if you see some untreated patient, you can notice that the canine is a little bit, not too much, a little bit tucked in. This is a great difference from the straight wire prescription. This and the torque that we have in the upper incisors.
That's really clear, and that's thank you. Was going to answers my next question, which is the difference between conventional straight wire and the bioprogressive theory. So that's very clear.
We have many other differences.
Can I can I ask you what would be the other main differences, just so the audience has some insight into straight
Yeah.
wire compared to bioprogressive theory?
First of all, I want to clarify that straight wire is a very it's a great tool, and I use straight wire obviously, but not to all my patient. Maybe I can say 60, 70%, not all, because we don't use the big differences is that I don't use a sequence of arches. I use a logical sequence, okay? And the first is the first approach is commencing, the starting procedures. So I want to, let's say that I want to open the bite, okay? So I use utility arches. Then step two is carry out. What is my goal is to open the bite, so I want to check if the bite is open. Okay, then I want, continuing is stage two, I want inter-arch or intra-arch correction. So I cannot use a straight wire. I must use sectional mechanics to preserve anchorage and to be more efficient. So I section and I just move the lateral part, just lay one side. If class 2 is one side, I move in a perfect class 2, and then I move the incisors, the front incisors backward, okay, with a retraction utility arch, And then I can go to the stage 3, that is consolidation and torque. So integration and torque is the step 4. So I can use now a proximal. We don't say a straight wire. It's a proximal arch. That means from Latin that I connect all the teeth. I can put loops. For this reason, is not straight. I can put loops there, but I want to maintain the torque. I don't want loose torque. I want to maintain the torque, open the bite. So integration torque. Okay, then consolidation. Okay, and then Ricketts change the idealization, because after ideal there is nothing. If you go ideal, you finish, and it's not true. So it's proximal arch, and then completing with the rotation and meta positioning. That means positioning the denture through the force of occlusion. Meta from Greek is through, means through the force of occlusion. This is another great concept that Ricketts introduced, but back in the 60s.
I love the fact that the prescription is less important, and I
Yeah,
love the fact that you still use straight wire and you go in between them. I think that's really insightful. And we had Madhu Padye on the podcast not too long ago from the States, and he was describing the use of sectional appliances, but also it's sometimes just simpler and easier just to use conventional straight wire,
yes.
pending the case. I want to ask you about intrusion arches. So we know the pros of them. You get control of the lower incisors, you get to be able to control the inclination of them, you get to get pure intrusion. But times are also evolving in terms of our modalities. So the use of temporary anchorage devices. Now, interestingly enough, there was a systematic review looking at intrusion arches versus TADS for intrusion for deep bite cases. So Sicily 2020 essentially showed you get better or greater quantity of intrusion of the incisors with TADs. You get less molar extrusion. This was a millimeter either side for these. My question to you is, in terms of practice, would it not befit the bioprogressive theory to use TADs for the intrusion, or do you still feel that the utility arches it has more merits?
Yes, I think that it depends on the pattern. If you have a brachyfacial pattern, you have no extrusion, you have no problem. You can intrude as much as you want. The problem is sometimes in dolichofacial patient, in patients that don't use the muscles, that they don't chew. This is a great problem in this period. Kids don't chew; they're swallowing because we give them very soft food, and this is really a great problem. So you must check and start from a great diagnosis and recognize from the beginning of the treatment the pattern. But I don't use my practice stats for intrude, because I have no problem. And I want to clarify also, thank you for your questions, the mechanics of the utility arch. And because when you put the utility arch from the first lower molar, okay, if you have the second molar in the mouth, you have a proclination of the lower incisors, because you cannot have a tip back of the molar. Okay, so you have intrusion, but your incisors will go forward. Okay, but if you put the utility arch in the last molar in the lower arch, let's say the first molar during the growth of the second molar, you have a tip back. So you intrude without any flaring of the lower dentures. You intrude and you have a tip back, and sometimes you have a crowding on the incisors, and so you must along the arches in order to not have crowding in the lower denture. So this is a great advantage of the utility arch, but you have to understand how to manage the utility arch. And I use studs when I have no teeth. So if I have no teeth, I must use implant or TADs in order to have some anchorage. But I think that cortical anchorage is it's great, and it's great because we use light force. Another concept in bioprogressive, that we use very light force. So we this is another way to preserve anchorage. If we use a lot of forces, it's easy to lose anchorage. For instance, during the class 2 correction, we use the section mechanics, and this is a great way to preserve anchorage because we don't move all the denture. We just have a section between the canine and the molar. And the Carrier copy this from the bioprogressive approach, the straight section. And they have a lot of problem because if you use the Carrier, you extrude the canine, okay, and you have a flaring of this section. With the section mechanics, you can activate it, and you can prevent all these side effects of the straight section that Carrier use.
Great. And especially if you're aiming to tuck in the canines, that's going to oppose your
Yes.
mechanics. Um, so when it comes to transpalatal arch, as you've mentioned, the opponents of the bioprogressive theory would say, well, the research doesn't support its use. There's studies by Stararos 2010, Zabalocki and McNamara 2010. They all showed that there was anchorage loss that took place with the use of transpalatal arch, but granted it was combined with straight wire. Do you think that actually this has been a misuse of the transpalatal arch, or do you stand by the research and would say, well, it's not perfect anchorage, but it helps? How do you see the research relative to what you're describing of the transpalatal arch?
One of the problem is the force. I'm not sure how much force they use. So if you bring a plier, you can extract the teeth if it's in anchorage. So I showed many times that I don't lose anchorage, and I want to that they clarify how they use these forces, how much forces in order to move how many teeth. And I want that they clarify the pattern of this. They don't distinguish the pattern of the patient. We are not equal. It's obvious. In brachyfacial, you don't need any anchorage. It's very difficult to lose anchorage in brachyfacial patient. In dolichofacial patient, okay, it's very easy to lose anchorage. So when you do a research, you cannot say class 2. You must identify the patient and the sample in the main characteristics. So when you speak about anchorage, then also again the pattern is critical.
In terms of the data, if we have a look at some more of the contemporary studies looking at facial types and anchorage loss, it seems to suggest there was Dezingel's paper just from this year, 2026, which showed that for straight wire, and again, maybe this is the key difference. The high angle, the brachiocephalic and the decacephalic don't have any difference in terms of the rate of anchorage loss. That seems to be what the research suggests. But do you disagree with that based upon, as you've already described, the force levels and the way that they're using their mechanics?
Maybe this is a key of to understand this research. Yes.
Because that's interesting. That points us in two different directions then, in terms of the bioprogressive interpretation of the vertical versus the straight wire interpretation of the vertical. And even anchorage values are different according to these two principles. That's really insightful. I appreciate that. I wanted to ask you about the anterior open bite cases. The bioprogressive theory describes the use of the MEAW, multi-looped edgewise arch wires, tip back bends in the posterior teeth, and anterior elastics. We all learn this in our residency, but doesn't tend to get used often, if at all, in conventional practice. I wanted to describe to you, was this just a theoretical exercise in describing the bioprogressive theory? Do you use this in your clinical practice? And what is the efficiencies of it?
Yes, I use the MEAW technique. I attended two Sato's course in the past, and I use for just in two cases in class three. Okay, because to me the MEAW technique is a straight wire mechanics, and I want to explain this concept. When I say straight wire mechanics, it means that you manage all the danger all at once. Okay, so it's very effective in class three. I mean dental class three, not skeletal. I don't believe that you can avoid surgery in all the cases. I have obviously surgery cases, and obviously you can avoid surgery with the class with the Sato mechanics, and with the very very great result. But surgery has a space in my clinics, obviously, and so I use in the class three in order to move lower denture backward, in open bite in order to close the bite, and in the asymmetry, because when we have because we used to think bidimensional. So when I said steep occlusal plane, I say like this, but we have two occlusal planes, one on the left, one on the right. So it seems that we, in one side, we have a steep occlusal plane, in that side we have a class 2. In the other side, we have a flat occlusal plane, and we can have a class 3. So with the MEAW technique, we can extrude one side, okay, posteriorly, intrude one side, the other side, and so we try to that the mandible can shift on one side, and this is great. This is one of the goal of the Sato theory and the Sato mechanics, and this kind of approach works very 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 well.
I think it's just the efficiency of it. It's a lot of wire bending, takes a lot of chair side time, and maybe that's the biggest hurdle with it in terms of clinical practice. In terms of looking now at retention, you mentioned about retainers. Now, as I was reading more about the bioprogressive theory, some proponents describe achieving ideal cos-fossa relationship in terms of the function, as you've mentioned, and therefore not needing any form of retention, as the occlusion or the function will maintain the dental position. What do you think of this? Is this something that you agree to? Is there contention with this? What do you think?
I want to say, first of all, that we don't look for a cusp fossa relationship, but inclined plane. If we have inclined plane, non-cusp fossa relationship. So this is we want Ricketts describes all this contact that is described as the key contacts, and he described 32 contacts on the denture. Obviously, some cusp to fossa, like the contact 7 that we have between the lingual cusp of the upper premolar to the cusp of the lower premolar. Okay, this is contact 7, very very important, and Sato think that the same thing, but we want to achieve a relationship between one teeth with two teeth on the lower. This is so the denture works on the inclined plane, And we think also that the lower denture, the lower arch is the arch guide, the arch guide, the guide. So for the upper, so we put a lingual arch on the lower first molar, a lower retainer, on bands that it's not very very beautiful. But if you don't, if when you smile, if you don't expand the lower denture, you cannot see. So in many patients don't complain about this, but it's very efficient as retainer. And then not always we use a removable Ricketts up the retainer, because we want that the upper denture adapt to the lower arch. And this is the concept of the meta positioning of the upper arch on the lower arch. So, and obviously, we want to check our patient, and I don't want to fix the denture. I hate the retainer for all the life. And I remember Sato once that the Sato doesn't use retainer. No? So if you ask to Sato why you don't use retainer, he answer with another question: why do you use retainer? Because you know that your job is not stable. So we have we must believe that the occlusion, the great occlusion, must preserve. Obviously, during the time, we must preserve our job, our finishing.
Okay, that's really clear. Um, Sergio, that brings us to an excellent conversation that we've had exploring the bioprogressive theory. And my summary and understanding is that there is still a difference in bioprogressive theory and straight wire, and the brachiocephalic, umbilicocephalic differences still remain in terms of how the mechanics are used and how that is then interpreted. I'd like to thank you very much for giving your time. I want to ask you one last question, Sergio. Somebody who has spoken and described principles of orthodontics for decades now, what advice do you have for the audience who are listening to this podcast?
And it's look the principles, and don't consider the malocclusion like a pathology, but like just a symptom. So treat and look not just the teeth, but behind a beautiful smile, like we used to say.
Thank you so much for joining me in the Orthodontics and Interview podcast, Sergio. I wish you the best of luck for your meeting on the 8th and 9th of May in Catania over in Sicily. Thank you so much for your time.
Thank you to you. Thank you. See you in Catania next May.